Hello, everybody. Welcome to the National Council on Interpreting in Healthcare's On the Road webinar focused on language concordant care. This is the third webinar in NCIHC's On the Road series, and we'll be talking about how do we provide that language concordant care in a way that is both safe and effective. I'm excited for this conversation and would love to hear what questions or comments you have, so please leave them in the chat or in the Q&A session here in Zoom. I hope we'll have time to get to some of your questions, but even those that we don't, we'll be sure to forward to all of our wonderful panelists today for them to include in any future conversations they're a part of. My name's Andy Schweeder, and I lead the language access team at Cincinnati Children's Hospital Medical Center. And I'm joined here today by four fantastic panelists, experts in language access and the law, who can hopefully help all of us learn a little bit more about how to be safe and effective in our jobs. I'd like to take a moment just to introduce them before we get started. First, Carla Fogaran has served as the System Director for Diversity Initiatives, Interpreter Services, as well as legal compliance for the ADA, 504, and Section 1557 at Steward Healthcare. She's a nurse and is also a pioneer in the field of medical interpreting. She was one of the experts that helped to draft the IMIA Standards of Practice way back in 1995. Welcome, Carla.
Thank you, Andy.
Next, we have Dylan Nicole DeCurver, who serves as the Senior Advisor to the Director at the Department of Health and Human Services Office of Civil Rights, providing counsel to the Director on policy and enforcement matters related to the office's non-discrimination authorities. She leads the rulemaking efforts related to Section 1557 of the Affordable Care Act, which prohibits discrimination on the basis of race, color, national origin, sex, age, and disability in a range of federally funded and conducted health programs and activities. Welcome, Dylan.
Thank you.
We also have Michael Moulet, an attorney advisor in the Federal Coordination and Compliance section of the Civil Rights Division of the U.S. Department of Justice. His office investigates discrimination complaints filed against recipients of federal financial assistance and conducts compliance reviews under Title VI of the Civil Rights Act of 1964 and other similar laws. He leads the state court's language access team, the limited English proficiency subcommittee of the federal Title VI interagency working group, and administers lep.gov, a great place to find information about federal laws related to language access. Welcome, Michael.
Hi, everybody. Thanks for having me.
And our final panelist is Dr. Tia Tucker, the Director of Health Equity at the Tufts University Family Medicine Residency Program at the Cambridge Health Alliance, where she designs educational opportunities for residents, including working with community partners to advocate for the health of all. Welcome, Dr. Tucker.
Hi, thanks for having me.
Dr. Tucker, could I start off with you? What is language concordant care? It sounds like a fancy word, but could you explain that to us in more normal terms?
Well, the easiest way to describe it at baseline is just that both people in the room, me as a physician and then my patient, both of us can speak the same language. A lot of the times in the United States, we say that, both of us can speak English, but some of us speak more than one language. And so it's useful to say we can both understand and speak to each other in the same language.
Thanks. So broadening that question, how is it that organizations can provide safe and effective language concordant care, and why exactly is that important? Dr. Tucker?
Yeah, so for sure. One of the things that's most important as far as being a physician is concerned, you want to be able to communicate with your patient. You want them to be able to trust you. And so the ability to have language concordant care is actually kind of a multi-pronged approach. In the situation that I'm in right now, working at Cambridge Health Alliance, we have an excellent group of interpreters that we can work with, and I can call an interpreter to come be here in person with me in the room. I can also do, we have televisit appointments where I can do a video with the patient and have the interpreter on the line for both of us. I can do that in person with an interpreter on the phone line at the same time. We also are trying to give more incentives to physicians to learn the languages of the community that we live in. But another big thing that we can start doing, or we should be doing, is actually recruiting physicians that speak these languages as well from our communities, because we know that people do well when they have people from their communities treating them. We also know that it engenders trust and a deeper understanding of the cultural values and understandings that you might not just get from a language course. I was told when I was in the Peace Corps about 20 years ago that I was never going to use Moroccan Arabic, and it turns out there's actually a lot of people in my community that speak Moroccan Arabic, so I use it quite often. Also, my training for being a physician was in Cuba, so I learned medicine, which is also a language actually, and Spanish at the same time. And I'm learning Portuguese, but it's never going to be the same as being with somebody who's from the community, who understands the difference between Brazilian Portuguese, Portugal Portuguese, and Cabo Verdean Portuguese. But I do think we need to incentivize a lot of that for our physicians as well. A colleague of mine, Jerry Milana, and I wrote an article about it. We also need to make sure we get more time during the visits, because interpreting during a visit takes 2 to 4 times as long when the patients don't have language concordant care.
Thanks. I really appreciate that perspective. Dylan, could you share the legal or regulatory perspective on this? What do organizations need to be doing to provide safe and effective language concordant care?
Absolutely. So first, I do want to acknowledge my colleague, Mike Millet. We used to work together. He's actually going to sort of lay the groundwork of Title VI of the Civil Rights Act, which is where we get sort of the baseline requirements. And then I'll follow up with the Section 1557 requirements, which are more specific to healthcare, if that's
awesome.
all right. Great. Mike?
Thanks, Dylan. Great to work with you again. And let's start. I know it's kind of the legal piece, but it's important because Title VI and its regulations require, if you are a healthcare organization that receives federal financial assistance, that you take what we call reasonable steps to provide meaningful access to persons with limiting English proficiency in all of your programs and activities. And meeting this meaningful access obligation includes giving patients with LEP notice of and providing them competent interpretation and translation services at no cost. And without competent language assistance services, a healthcare organization cannot get the information it needs, as Dr. Tufter was talking before, and they can't provide medical care that person needs. So if language barriers are not removed, or patients with LEP are permitted or told by staff or others to bring their family members or friends to serve as interpreters, the results can be serious or fatal for the patient. And related, and I just want to point this out because I think it's important to connect it to professional obligations that a lot of us know, but just to make the connection, when we look at something like the American Medical Association Principles of Medical Ethics, they provide a few things that are kind of requirements. They say that a physician shall, and it says this, quote, be dedicated to providing competent medical care. That's exactly what I'm talking about. To respect the law. That's what I was talking about too. And also to support access to medical care for all people. I think those work really close in tandem with what we're talking about when we're talking about if it's a health organization that receives federal financial assistance, which a lot of them do. I think those line up really well with understood principles of medical ethics that a lot of medical practitioners understand. But I'm going to pass off to Dylan for the specifics for the medical context, because I was just talking generally about Title VI obligations.
Great, thanks so much, Mike. So Section 1557 of the Affordable Care Act applies specifically to health programs and activities. And HHS has really done our best to provide additional details. So some might call it guidance, it's required. And with that, as many of you know, we've undergone a number of revisions of this regulation. Thank you to those who provided comments on our recently issued notice of proposed rulemaking. But in that NPRM, we recognize the value of concordant care. And so we discuss it as a form of acceptable language assistance services when provided by a qualified bilingual or multilingual staff member. And so what we tried to do with this regulation in the proposal was provide some guidelines around what does that mean? When we come in to enforce, what are we looking for? And so that means, as we've defined it, being proficient in speaking and understanding both English and another language, and where there's a knowledge of the specialized vocabulary, terminology, and phraseology. And you have to be able to effectively, accurately, and impartially provide this communication. And so, we really, again, value the concordant language conversation, but understand that not just anybody can provide it, right? And so really, I know we're going to get into some more specifics as we go along, but that qualified language service provision is really what 1557 drills down.
Thanks. And before we get into those specifics, I want to make sure we're clear on who this applies to. We mentioned people that receive federal financial assistance for healthcare. Dylan or Michael, would you like to go into who exactly are we talking about? Who does this Title VI and more specifically Section 1557 apply to?
Well, Title VI is very broad. Title VI applies to any program or activity that receives federal financial assistance, and that has a very specific legal definition. But it pretty much means all the operations of an entity, which can include a private entity, it can include a nonprofit entity that receives federal financial assistance. So, sometimes there was confusion in the past about, well, if this one part of the office receives it, does that mean the entire office, or does it just mean that one part that receives the federal financial assistance? And because of that confusion, Congress clarified that it was meant to be the broadest possible application of all of the operations. And so there's a lot of cases on this explaining that it's a broad application. So even if one part of a program or activity, that means all the other parts then too have to comply as to Title VI, which is kind of a floor. And I'll let Dylan speak specifically as to covered healthcare entities, because I think that is more precise and specific for this conversation.
Thanks, Mike. So for Section 1557, we're limited to health programs and activities. For those of you who might be familiar with Title IX, which prohibits sex discrimination in education programs and activities, 1557 is sort of similarly limited. But HHS funds a lot of health programs and activities. And so this includes Medicare payments, Medicaid payments, all different types of grants that support research. And like Mike said, that language services requirement isn't just for, say, Medicaid patients, if that's where the federal funding comes from. It's now for everyone in your facility.
Thanks, Dylan. I really like the clarity that Section 1557 provided about those covered entities, saying that, and when an organization's primary purpose is healthcare, and they accept federal funding for healthcare, it covers all of their operations. And we can't just slice and dice to our Medicaid patients or our medical content. It applies to everything. Thanks. So turning then to those specifics for language concordant care, what is the expectation for organizations? Do we need to be creating language proficiency assessments for staff, for which staff, or for patients? What are we supposed to be doing here when we want to provide language concordant care? Dylan, do you want to talk about what's required, and then Carla, maybe what you've done?
Absolutely. So as I mentioned, we don't have any current regulations that require a certification or anything like that. But when HHS receives a complaint, and this is similar to the Department of Justice and other federal agencies, we look to see what a covered entity has done to ensure that, for example, the language services that are being provided are being done in the appropriate manner. And so, as I mentioned, with this definition of qualified bilingual or multilingual staff member that we're discussing, we will look to see how a covered entity assessed whether or not that person really was competent. And so, again, we're not necessarily looking for a certificate, though that could be one way that you show you've taken the steps to ensure that your staff is competent. we will be looking at, any assessments that were done, any training that might be provided. And then, we could, if we needed to, do an assessment ourselves to ensure whether or not that person has the appropriate skills.
Thanks. Carla.
Well, for us, what we ended up doing, because we were a large healthcare system with 40 plus hospitals across 11 states. In all honesty, I'm not going to lie, this was one of the most difficult professional things I've had to do. The first 18 months were horrific. I was black and blue almost every day. Clinical staff kept challenging, why do we have to do this? I was born in Cuba. I went to med school in Cuba. This is ridiculous, another thing for us to do. And in all honesty, as a Portuguese speaking nurse myself, it was somewhat frustrating thinking about my not being able to provide care and comfort to a Portuguese speaking patient. So I could understand from their perspective how frustrating this additional barrier in an already a land with minefields everywhere was for them. But, we put into place a huge marketing campaign, explaining the whys, the benefits, the legalities, right? And also, please, whoever's thinking of doing this, don't do it internally. They wanted us to do it internally through the interpreter services department, and it would literally be me failing Dr. Smith, and it would not go well. So we, contracted with a partner, a vendor that did nothing but assess language proficiency in a clinical setting, like medical. So that to me was extremely important. And we ended up getting several thousand people to comply. And we had 48% passing rate, just to give you an idea. So that means that 52% of those folks were not at the level that they should have been. So, when the candidate failed, it was almost like I personally eviscerated them. Like, I go to church in that language. I speak to my family in that language. Who are you to fail me? And my answer was always typically, I'm not saying that you can't speak the language. In some cases, there were some that should never open their mouth in that language. But what I'm saying is that you don't have the clinical depth and bandwidth to be able to communicate in that language. I'll give you a quick example of a physician who was not happy that he failed. He was an endocrinologist. And, I said, you speak the language, you just don't have the terminology part, the clinical aspect. He came back to me a few months later and he said, I was paying attention. And for an English speaker, I can talk to them about the A1C for at least 10 minutes. But for a Portuguese speaker, it was 2 minutes. And it was more like, you have sugar in your blood, stay away from sugar. And 9 months after he did not pass it, he came back and he passed it because he dedicated himself to learning the terminology. I can't teach him the language, but people can learn the medical terminology. So it's just a very important thing that we need to do. We need to make sure that however we do this is safe and in a vetted way that leads to whether the patient feels heard, a doctor is able to treat them, are they assessed correctly, and is the right diagnosis made, and can they follow the treatment? So hope that answers what you asked.
Absolutely. One question that I've seen here in the chat as well as in the past is, are we assessing people's English skills too here? Do we need to be doing that? Isn't that part of this? Carla?
Okay. All right. I got that question all the time from people that weren't very happy in some ways. It's like, sometimes we need an interpreter to understand some of the staff and the doctors. And I'm just saying that that's a reality, that people don't listen well to people who have accents. And then they get nervous and then they shut down even more. So, my response was always, well, no, this purpose of this is to assess their target language. They go through med school, TOEFL exams, and all sorts of other exams to assess their English. That's not my role in this. This is not my expectation. My expectation simply focused on the target language to make sure that care can be provided in an effective manner with harm does not happen based on the inability of the provider to speak and also to understand. Equally important. I mean, you don't want to just speak in another language. You want to be able to understand what that patient is saying.
And Andy, I was going to say too, generally we provided consistent advice. I'll just tell you from the Department of Justice, no matter who the type of entity is. And we've said consistently that without an assessment of your staff, you really don't know, like Carla says, if that person is competent and if they can provide that meaningful access. I mean, competency, and this is Carla's point too, is more than self-identifying as bilingual. Right? That is I know it pains people, and Carla gave great examples of how it kind of personally was offensive to people, but that is a reality. Someone who has had their language skills assessed with a verified test has demonstrated their knowledge of English and specifically the second language in medical settings and all related ethical and professional requirements. That's what we're talking about when we're talking about competent. We're not talking about, like Carla said, general knowledge and what you used to talk about when you were in your house. That's not this setting. That is knowledge, but it is not this setting. It is not the setting we need. And without an assessment as a healthcare organization, you don't know if that person is competent to provide direct care in language, whether as an interpreter, or some people just assume you automatically have the skills of a translator too. I know that's not what we're talking about today, but sometimes people just assume, oh, I heard her speak Spanish. Can you do, that is a different skill. And that is assessed in a different way. So I know that's not what we're talking about, but sometimes people have this notion that, oh, they identified some language skill, therefore they are both specialized, they're both specific, and they know both need to be assessed independently. And if not, there are serious health implications for that patient and liability for that hospital or that medical provider, right? To Dylan's point before, we checked, they weren't assessed ever. Their skills were never demonstrated to be competent. This serious medical thing happened, maybe even fatal. That's gonna play out in a terrible way for that healthcare institution.
And in all honesty, Michael, that's one of the things I used as well to my benefit. I'd say, people can sue you because they don't like your tie. So can you imagine in the medical field where this is a little bit more serious and, people can sue and some should sue and whatever else. But the reality is that at least you can stand and say, I was independently vetted through an outside vendor that does nothing but assess bilingual clinical fluency. And our score had to be a 90 or above, because I worked with very good risk managers that said that the Joint Commission doesn't want B- people taking care of our patients. So we had some very stringent passing rates. But, the credentials, we called that, they were credentialed. We didn't want to use the word certified because that causes a lot of confusion. So we said they credentialed. We would put the passing credential certificate, Dylan, into the medical staff office, credentialing office, if they were physician and NP, a nurse practitioner, or physician assistant. And then for all other staff that was clinical, it would go into their HR file. So when Joint Commission came by, Dr. Tucker, and heard you speak Spanish, they would say, I'd like to see her personnel file, and it's listed right in her personnel file. So you really have to tighten up all of the potential risks that will lead to those unfortunate aha moments where you get dinged by a regulatory agency because you did one piece of it, but you didn't do the rest of it.
Right, or gaps in people not having their skills assessed, but using those skills when working with patients or families or the public. Dylan, you wanted to jump in?
Oh, I was just going to say what somebody actually said in the chat, which was, if you're, bilingual, qualified, assessed, credentialed, you might not be qualified to be a translator. You might also not be qualified to be an interpreter, right? So just because you do have, say your nurse practitioner who can provide concordant care, they might not, be qualified in the interpreting skills that they would need to be qualified. So I'm sure I'm speaking to the folks that already know that, but it never hurts to underscore.
Right, and I think that the definitions you and your team have provided in section 1557 are very helpful in simply pointing out what those differences are between a qualified interpreter, a qualified translator, and qualified bilingual staff.
Thanks. We love to hear it.
So looking then at a little more at those specifics, Carla, you mentioned that there was a specific test score that you had in mind, as well as a number of different roles that potentially were being tested, providers as well as other staff. Would you like to go into a little more detail? I mean, was everybody taking the same test? Did everybody have the same test score they needed to get?
So it was for nurses, for anybody that was clinical, including certified nursing assistants. So we really gave the option to all people. Now it was voluntary. So you can imagine that a lot of people did not want to take it, but that was okay. If you didn't want to take it, that's fine. However, you would not be able to speak to a patient clinically without the assistance of engaging an interpreter. If you failed, the same thing applied. You had to engage an interpreter for each and every encounter. That's the part that drove people crazy. They literally thought that they could go in and introduce themselves to a patient without an interpreter at the beginning of their shift. And I'm like, well, why would you treat Mr. Gonzalez any different than you would treat Mr. Smith? When you actually tell him who you are and that you're going to be caring for him for the next 8 hours, et cetera. I said, that's discriminatory in nature. You really have to provide the same level of care to all patients. And if it's a language issue, then you have the resources to be able to mitigate the gaps. And we all know that, for me as a Portuguese speaking nurse, it'd be a lot easier for me to just open up my mouth and speak, as Dr. Tucker will probably attest to as well. But certainly I used interpreters, I hate the word used, forgive me. I engaged interpreters when all other languages that I was not qualified in. So we would make this available to any staff person that was clinical. The testing, the tests are available for medical doctors, PAs, and NPs, then nurses and nurses assistants, and they are at different levels. And you also have to make sure that you are very careful about not taking a wonderful front desk registration person and holding them to the level of what a nurse would take, because that's not the job level that they do. And you have to really meet the job level, because it infringes on labor laws, from what I understand. I'm not a lawyer, but that's what I've been told in my past life here. So, any staff that wanted to take it were given a self-assessment. To Michael's point, most of the people always assess themselves higher than their actual skills are, but they were given a self-assessment. And if they met a certain level, they were eligible to take the assessment. They take the assessment, and within 2 to 3 days, they have the results. And if you partner with the multiple vendors out there, make sure you look for someone that's actually going to give feedback, so that the provider is not just left with a failing grade, but they actually understand that this is the areas that they need to work on, or this is the issues that were identified.
Thanks, Carla. Dylan or Michael, do you want to shed any more light on the requirements and how that program aligns with the different roles and different competencies?
Well, I mean, I could talk about in-house kind of what we do at DOJ, and I think this might be actually marry really well with what Carla just said.
Yeah.
I know it's an entirely different setting, but at DOJ, just like Carla said, for her staff are not required to have their language skills assessed, but they can't provide in-language services in that non-English language on behalf of DOJ until they've demonstrated their competency by taking an assessment that uses their interagency language roundtable scale, which a lot of entities use the ILR scale. And so staff that have frequent interaction with persons who are LEP or have a work plan, to Carla's point about your work responsibilities, I think that's a really good one. That includes providing language assistance services. They're encouraged but not required to undergo a language assessment that is conducted by, and we have a language testing assessment unit at the FBI. They specifically provide a ILR-based test. It uses the ILR scale, which, if you know it, it goes from 1 to 5. And to go from a 3 to a 5 is an incredible level of skill. I mean, for someone to be a 3 or someone to be a 5, it's a very, very distinct and magnitudes greater skill if you're a 5. But it provides scores, like Carla was saying, it provides scores at skill levels, but the skills are specifically reading, listening, speaking, and writing abilities. And you get feedback on all of those, and you get a score on all of those. And depending on the score the person receives, parallel to what Carla was saying, for each skill, they may be authorized to provide specific language services on behalf of DOJ for those specific types of settings. Not all, but for specific types of settings that match their skill level. Again, it's a verified test. They've been assessed. They've demonstrated their competency. And It's for the skills that are related to their job. It's of no value for them to serve as a translator if we don't have that need, right? So it's only for the skills that are related for their job performance. And I just want to note that a lot of private language assessment and testing providers for a lot of different types of interpretation and translation use that ILR scale to assess language skills, or versions of the ILR scale. But it is pretty consistent. You need that verified test with a scale that does measure specific skill sets, not just, can she speak Spanish? That's not going to cut it again.
I was just going to add that I feel like pride and ego play so much of a role in this, as well as, trust and lack of trust. Really, as a provider, you really got to remember that your patient's safety is at risk if you can't speak. So I know I'm a little bit biased because I grew up just speaking English. I'm not a native Spanish or Portuguese speaker, so I don't get that same kind of blow to my ego when somebody says, your language skills are not good enough. Or if someone had said that to me. But you really got to attack it also from, an anti-oppression, anti-bias, anti-racist kind of lenses too. And your job as a physician is paramount to providing health equity. And so that means that that means excellence. If you can't provide excellent care by having excellent language skills, then that means that you just said that your patient just deserves what's good enough. And that's not safe. And I can't imagine any doctor, if you went into a room and you said, well, I did a pap smear, but it was just good enough, or I repaired this, this laceration, but it was just good enough, that anyone would accept that. And so, part of your communication skills as a doctor are super paramount to health equity and patient care. And that's how I think about it when I walk into a room. And so my learning anecdote in this experience is that, I took the Spanish test. I found it difficult, even though I think my Spanish training and medical training is good. And it really inspired me to not take the French test, which I speak fluently. And I did not take the Moroccan Arabic test, which I speak pretty well, because I realized that, my skill set in Moroccan Arabic has to do a lot with politics and talking with families and talking about like food and cultural things. And the same thing, I went to school in France, but it was for politics. I could not describe to you what the thyroid does in French or in Arabic. And so I do not conduct visits in those languages, even though my patients do know that I speak in those languages. And it's very hard from the patient perspective as well to hear. I cannot tell you how many people in our community will say, like, why won't you speak Creole to me? I heard you say Kijanu. Yeah, I know you know. Why won't you speak Creole to me? And you have to kind of attack it from the perspective that you deserve a visit that's in the language that you speak. And you deserve to be able to trust that the person that you're talking to is going to understand you. And maybe you've had like experiences, a lot of my patients have experiences where they did not have the trust that they needed with the provider, and they've been used to just good enough. And so those are the patients that come in the room and they say, oh, I don't need an interpreter. So what I say is like, well, I do. I'm the one who needs an interpreter. I can't do the visit this way. I'm sorry. Your Creole is excellent. I can't speak Creole. So we're gonna use an interpreter because you deserve the time and you deserve the access. Instead of saying, I only got 20 minutes, let's go ahead and, we'll try our best. That's just not good enough, and the patients deserve better.
Thanks, Dr. Tucker. I really appreciate that perspective. I think when we look at the legal requirements, we tend to see things in a little more black and white way. But when a patient comes to you and wants to speak a language that you speak, saying no has to be difficult. I'm really grateful that you do. Thanks. How did getting qualified for Spanish change your practice, Dr. Tucker?
It made me feel a lot more confident when I walked into the room, knowing that, there's other people. I felt pretty good at baseline, but there was other people that my organization trusted me to be able to provide care this way. And being able to know that when I walked into the room with the patient that, I wasn't doing anything that I shouldn't be doing. I do have a friend that I work with who speaks Spanish, and they're also not a native speaker, and they were trained in residency to speak Spanish, and has not been able to pass the test. And, it's kind of a sore point with them. Because the patients that they see, they really trust them and they like them. And I've seen like some comments here in the chat it's kind of that situation where somebody has been doing this for years, and then when they have the opportunity to get certified and they can't, it's kind of painful for them and the patients to kind of figure out, well, what should I do now? That physician does use an interpreter, but I know it's very difficult for them when they know that they might be able to move a little bit faster. But I think they really believe in the quality of their visits. And the interpreters that we have here at CHA are actually like super talented and very kind. So even though my Portuguese is meh, you know, I'm working on it. Sometimes I do notice changes in what we're saying, you know, things that are not correct. And I really like the way that they apply themselves to the visit, that if I do say, oh, I didn't say birth control, I just said the IUD, and it's very particular and that you say it just like that, that they will say, oh, yes, okay, yes, and it's that. Or I had a lovely experience with an interpreter right in the beginning of my training where I said, I noticed that the patient was saying chest pain, but I thought they meant stomach and did not know, because I'm not Creole, that that word actually applies to the trunk. And you would not know that unless you had had the experience of living in that culture with people. And so the interpreter knew that and was able to tell me, no, the patient's words are correct. You just didn't understand the context of it. And that's the beauty of having the interpreter, is something that even if I had learned Haitian Creole and was good, I might not have learned that aspect of it. I'm very thankful for them for that.
Carla.
I will say that you are an amazing person, Dr. Tucker. I'm so honored to meet you, and I'd like to clone you and send you everywhere. But you know, there's also the other side. You're always going to have people that are rogue, Andy. They do whatever they want when they want, and their motto is proceed until apprehended. You know, and it's really difficult to deal with that. But so many patients over my years of experience, because I feel like a fossil in this industry, have said to me, you know, the doctor comes in, for instance, they really appreciate a kind person, and they're very, very polite for the most part. And they nod to the doctor like they're understanding, and the doctor comes in and does something, says something, and then the interpreter does their rounds. I worked with a wonderful team of interpreters and interpreter managers. They would do daily rounds, and they would say, oh, I'm so glad you're here. You know, that nice nurse or doctor just came in and they said blah, 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 blah. And I know they're going to do something to me, but I don't know what they're going to do. I mean, it's frightening enough being a patient that understands what's happening, but not to understand, or maybe to understand every third word, you know, it's just unacceptable. It's just deplorable. And I think that my challenges, and believe me, I've had to go toe to toe. I mean, toe to toe with some doctors. I actually would put on my RN badge if I was doing presentations for physicians, because they listened to me a little different, you know, and I'd go toe to toe with them. And I said, I know you didn't get up this morning and say, I can't wait to mistreat my first Spanish speaking patient. You know, no one is in this field to do harm intentfully, but by not following what you need to do, you are intentfully going in there and almost doing harm, because that patient's not getting the same level of care, and therefore they're being readmitted or come to the ER again. And how many times have we all heard, I don't get this, these people are so non-compliant. And it's not that the patient's necessarily non-compliant, it's just they don't know what to comply with. They don't understand the discharge instructions. You know, they can't even tell the physician that just ordered some, you know, a medication that costs $140, that if they choose the medication, that means there's no food for the family for the week. You know, and if they were able to have language concordant care, or at least an interpreter present, that would become a lot more possible for them to then, you know, come to some sort of compromise. Maybe there's another medication, maybe there's a couple of things that can be changed, because you don't want that patient to leave the walls of the hospital, go out there and then fail, and then, by the way, have to follow up with their primary care doctor. And a lot of primary care or physician practices do not have language access services. So here we are taking care, hopefully, of the whole person in the hospital, then pushing them out as fast as we can. And then they have to make the phone call, get through. Sometimes they're told, bring someone that speaks your language or we won't be able to see you, which is so against law. But I think that some of it is just ignorance. A lot of people don't quite get it. And then some of it is they just don't want to get it. So I am so thankful for Dylan and Michael and all of the work that's being done to get this out there and to make it as simple as possible. Because as a dear friend of mine who is a lawyer says to me, it's not like these things have changed. They've been in place for a while, right, Michael? They've just been augmented and finally said, hey, listen, you didn't get it the first time. You didn't get it the second time we said it. So hopefully this time you'll understand it because we're really breaking it down for you. So let's keep our fingers crossed.
I really like what
I
you
think-
said about the difference between intent and impact. That I talk to the residents about this a lot because there's so much with trauma-informed care when you're talking to a patient and you do something wrong, or to a person and you do something wrong. And the first thing that people say was, I didn't mean to, I was just trying to finish the visit quickly. The patient wanted me to talk in their language. I wasn't trying to do anything wrong. We often say that like the impact outweighs the intent. The intent is good to know, like forgiveness is great. We want to forgive each other and not cancel each other so that we can live together and move on. But making sure that you say, I like how Carla said, like, you might not have meant to do it, but the impact to the client or to the patient or to the person, sometimes it takes longer to repair when you ignore your impact over the intent that you had.
This is Eliana. I have a bunch of questions clustered around reassessing staff as well as consequences for staff. So if you don't mind, I'm going to throw the whole bunch at you and you can decide who answers which question. So Emily asks, Carla, did you offer pay incentives for staff that pass the certification test? And I know there's lots of places that do and lots of places that don't. And
So,
sorry, let me just throw
yeah,
them
sure.
all in for you. Roxana asks, how do you monitor those that don't pass to ensure that they're not sneaking into providing interpretation? And then Sherry asks, what happens when a provider has been communicating for years, as you've just been discussing, in the target language and then does not pass the assessment? And Nicole asks, what guidance do you have for reassessments since language skills can decay if not used? And then finally, Dale asks, what are the possible consequences for a provider that has been providing care in a target language for years, but then does not pass the clinical language assessment? So all in a big bundle for all of you. Let's start with Carla.
Yeah. So we would allow reassessments when I first started this in 6 months. If somebody, like sometimes it was like just a couple of points and, nothing personal, but I myself get nervous when I'm assessed, and I took all 3 assessments, one for nurse, the physician assessment, etc., because I really strongly believe that you have to be completely versed in what you're asking people to do. So if you're able to take the assessment yourself, please do, because then when they challenge you, you know what they're challenging you on. So before I left, though, I changed that. I didn't go to 6 months. I changed it to a year. And I'll be honest with you, the people that were failing were not going to pass it in 6 months. They were told what they needed to work on, and hopefully they would work on it. But I just felt like I was paying and spending money on something that really wasn't doable. As a matter of fact, when they got their assessments where they had to self-identify what level they were at, I noticed that a few people would actually take the assessment, and I knew their language skills were like very low. And I'd say, well, why did you take it? And they said, what the heck? I figured it was worth a shot. And I'd be going, oh my goodness, that you're not going to pass it. And well, I kind of wanted to know what level I was at. Well, it was like 0 to 2. You're at a very low level. So we did not pay extra. We did not get give an incentive for the language, for passing this. I think that there's talk about changing that, but I'm not sure. I'm no longer there. But we did not pay an incentive for that. And we were asked constantly, will we get paid more? And we said, no, but we'll pay you to take the assessment and we'll pay for the assessment. So we paid them for their time and we paid them for their assessment, because you can't expect somebody to do this on their own time. I don't even think that might be, legal in some cases. So that's what we offered. And then for those providers, and we had a few, we had a provider that went to Haiti on mission work during the earthquake. And the man is honestly one of the best human beings I know and a great physician. And he could speak Haitian Creole, and he started creating or getting a gathering of patients from the Brockton area that were Haitian and wanted to go to him. But he did not pass it the first time around. He really didn't. He was close, but he didn't pass it. So then he was like, what do I do now? But luckily for me, all of the physician practices that were part of the system had video and phone interpreting available readily, like all the time. So in the interim, he was able to work it out that way. But I was so thankful when the test results came back and he passed, because honestly, the community needs it. The community needs to feel that they trust the physician. And it was a real ethical dilemma for me, because I knew the great good that he was doing, but it was just standard across the board. If you don't pass, you have to engage an interpreter. And then the other question was about, I went to school in Lebanon, med school. I would hear, presumably I could not have graduated without being fluent in Arabic. And our risk managers really felt strongly that they just wanted to hold everybody to the same level, because you could have been practicing in a state where, for 20 years, you've never seen an Arabic patient. So you haven't been using your medical skills, fluency level, and your language can deteriorate, if you're not assessed. The one other thing that I wanted to mention is that from a Joint Commission perspective, staff have to be, there's annual competencies have to be done, whether you're a respiratory therapist, a phlebotomist, a nurse, etc. And there is, a good practice would say that if you pass this should become part of your job description, because you should be assessed for it. People should be doing a competency on it annually or checking in on it, etc. We were just about to get to that point before I left. But, the physicians or the staff that continue to do the wrong thing, even after they've been told not to, it's imperative that you try to do a one-on-one discussion. This is not to humiliate anybody. Their intent is good, as Dr. Tucker said, but try to approach them one-on-one and just say, hey, listen, I noticed that you were speaking clinically. By all means, if it's casual conversation, like, your daughter called, how's the weather? But at any moment that can turn into the patient saying, I'm having chest pain, right? So I said, please consider taking the assessment. And if you don't take the assessment, then please, you have to utilize an interpreter each and every single time. And for those that did not comply, even after repeated meetings, then it would go to their supervisor, and then there would be some disciplinary action as a result of it. So it wasn't necessarily that I was everybody's favorite person at the time because of this, but I honestly left knowing that we made a great change in the culture, and that people people know their level of proficiency. They really do. They know that they can say to their sister, pass the chicken across the table, but they can't talk about a cholecystectomy or salpingo-oophorectomy in the same level. So I don't know if I answered all the questions, because I haven't interpreted in a while and my memory is not what it used to be. So if I missed anything, forgive me.
No, that's fantastic, Carla. Dylan or Mike, do you want to weigh in on this reassessment idea?
Well, what I'll say is that, we've definitely been asked it. I've been asked it in my enforcement work. And, one of the things we say too is that currently the federal government is not the one that sets the certification test, right? There's no national certification that is put out by the federal government. So we don't set either the score you have to get or the test you have to take. Like Dylan said, there's a variety of things people come forth with that when they're just demonstrating competency. And similarly, we don't say, what is the right time to get reassessed. But when we are working with an entity, particularly in a civil rights matter, we do talk about this. We do talk about the practical steps of, okay, like Dylan said before, show me that assessment you use. Show me how you make sure that this happened allegedly, or it did and we proved it, and that was a real problem. But show me this is not going to happen again, because you have what? The periodic assessment is when, right? When staff are onboarded, they'll be given training on how to work with an interpreter, how to require an interpreter. We ask for things like that. It's not just all about staff who provide service in language, it's also staff understanding with how to work with patients who are LEP in general. You know, so there are things that we require because there are these practices. We don't regulate the certification for interpreters, we don't, or their periodic reassessment, but there are other things around that that we need to make sure, okay, he says now, you know, he just passed, what's in place to make sure that 2 years from now he can demonstrate that exam? You know, how do we make sure staff can periodically do that? Not just while we're here, while we're doing this review or this investigation, but it's part of your standard operating procedures. So when we're gone, we can be sure or comfortable with the quality of service that you're going to provide meets, you know, that meaningful access to kind of standard. That's what I would say.
Thanks. I think that's really helpful. We were also talking a little bit about the consequences of not being assessed or not working with an interpreter. From the legal and regulatory side, Dylan or Mike, what are the consequences here?
So I think from the civil rights side, that's a very different question than one you might have with your general counsel, for example, who can discuss sort of the malpractice issues associated with not providing appropriate language services, resulting in, you know, diminished quality of care. The way, you know, both under Title VI and Section 1557, we are statutorily required to work with a covered entity towards voluntary compliance. And so when Mike and I used to work together, I used to say we were the cheapest form of technical assistance you could get if you would just work with us, right? So we often, as Mike was saying, we work with, right? We do our investigation, we have that enforcement, but also at the end of the day, we want to make sure that this never happens again. And so how can we help build up a program so that folks are thinking about assessments, they're thinking about reassessments, they know the difference between, you know, in language concordant care versus interpretation versus translation versus grabbing somebody from the, you know, restaurant kitchen next door, which we have seen in investigations to provide interpretation, right? So even this conversation is one that we often have to have with covered entities. But at the end of the day, if you don't want to work with us and we find a violation, there are one of two routes. One, we can take a covered entity to federal court, or we can move towards fund termination, which could mean losing all Medicaid payments, losing all Medicare payments. So those are pretty big hammers that we have. And
also related to that, we would let any other federal agency know that provides you funding. Hey, we tried, like Dylan said, we tried to resolve this voluntarily. We made every effort. Would really, you know, you might have, I know they might be up for a new round of funding. Maybe this is not the right one. Maybe you should go to an entity that can demonstrate they can comply. We don't want the money wasted either. We want to go to entities that can comply. This one has not demonstrated it. So there are ripple effects. It's just not the individual agency. We have an obligation to reach out to our other sister agencies and say, look, we've tried. This is an actor that just doesn't want to do it. It's an obligation we all have. It's an obligation they have. They refuse to work with us. You know, it is, you know, after we've tried to exhaust that voluntary resolution, but it does happen sometimes. And that's what we have to do. We can't have federal money being used in an institution that's discriminated. That's just not allowed. That's just not going to happen.
And so then how do we bring those big picture consequences down to the individuals? Carla?
I can only tell you that it's repeated education. And then you repeat it and repeat it and repeat it again. I mean, honestly, like, I can't begin to tell you. So we had monthly newsletters. We held monthly webinars, always bringing in these little pieces. It's almost like through osmosis. I was hoping that it would just infiltrate like the Walking Dead scenario, and people would get infiltrated with this virus that would allow them to get it once and for all. But, you know, you've got to give CME credits for risk management if you're going to do this. Risk management CMEs are hard to find. So do your presentations with that in mind. You got to dangle that carrot. What's in it for me? Always have food because they're always hungry. But the reality is, you know, talk to the nurses, be part of the practice councils, be part of orientation. And when I say part of orientation, not just, yes, you have to do this, but engage the audience in asking the questions. programs, bring the devices that are going to be their resources, talk to them about making sure that it's in their packet, that they can be assessed for we used to call it the Bilingual Clinical Staff Language Assessment, the BCSLA. And, talk about how diverse the community is. I would have nursing student orientations, any chance you got to kind of plant the seed, residents, hospitalists. Oh my goodness, hospitalists. A lot of our hospitalists, at least in Massachusetts, were from countries that didn't represent the demographics of the community. So it was a lot of languages that they could speak, but however, it didn't represent the demographics of the community. And they would volunteer to get assessed. And I'd say, yes, it doesn't matter whether it's 5 patients or if it's 3 patients. I want you to be in a safe environment. I want you to provide the most excellent care. And we will have a patient that speaks Arabic, maybe at St. Anne's in Fall River, which is mostly Portuguese and Cape Verdean and Spanish, right? But, it was just having conversations, being open to criticism. Oh my gosh, I was open to such criticism, but holding your ground. You cannot let them see you sweat. Okay, you got to just hold your ground, but getting champions like Dr. Tucker, having webinars like this, and then sending the recordings to all of your risk managers, all of your compliance folks, hello folks, and then to your administration. It really does help, because if they start hearing it from all sorts of people and not just Carla, who's passionate about this, or, oh, Dr. Tucker kind of loves this thing. And they start hearing it from Dylan and from Michael and other people. They pay attention to it, and then they can see how it has an actual return on investment for them. Because at the end of the day, you could be mission driven, but mission without margin is not sustainable. The hospitals have to make some money. And, and already they have suffered a lot of cuts and through COVID and everything else. But if you can actually prove that this is a return on investment, an investment in their social community by providing trainings, maybe even medical interpreter classes, right? If we have a shortage, why not provide it? Host it at the hospitals. So, but it's the educational component and the champions. I was lucky enough that when I started this 5 years ago, I had a chief medical officer who was phenomenal. And he wrote a memo out to every single physician stating that this was the expectation, not that this is a nice thing to do, that this was the expectation for those that were bilingual. And if anybody was giving me a super hard time, one that I couldn't handle, he wanted them referred to him. And he would have that one-on-one with folks. And in all honesty, once he set the tone, it was much easier for me to succeed in this organization. And remember, it was challenging. It wasn't just one state. It was across 11 states and 40 hospitals. Very, very difficult to do in one hospital, but a lot more challenging when you have multiple hospitals.
Thanks.
I mean, the other thing I
Michael?
was too, along the lines of what Carla's saying is, this is when people are past their medical education. I think there's definitely a lot to be said of, like, we have to catch up because this topic is not covered while they're going through medical education, right? That's why we're talking about all this, right? We're having the institution. This is a conversation we have, in our enforcement work too. We work with police departments. It's not covered during their training academy, becoming officers. So we have to, and what Carla's saying are excellent ways to do it, but you are playing catch up after, because it is not understood to be part of how you provide care. It is an add-on. Anytime anything is an add-on, it's as hard as Carla has just been explaining, right? Because it's not part of the care model. It's not part of the education, right? It's not part of, like you said, your required medical credits do not require you to take a course on this to brush up, because, like you said, Carla, the first time you ever heard about it was in that presentation you gave in orientation. I've never been exposed to it at any point, educationally or clinically. Say I was in, a clinical setting, or, in my last year of medical school, I was practicing enough. It was never covered. So I find there's also this education piece that's really important, where if it's not covered, I'm not saying you magically know it, but you just never had an exposure. So Carla's the first time to hear about it in that one meeting, that one time. And I think that's significant and shows a gap, definitely, that I think needs to be addressed.
But
Dylan?
again, just like,
Yeah.
oh, sorry, Dylan, go ahead.
No, go ahead, Dr. Tucker.
I was going to say, just like any kind of medical procedure that you're not cut up on anything new, like in medicine, things change all the time, and it's our job to get caught up with those things. And I really like what people were saying about incentivizing. For physicians, and I do know that a lot of us have problems with ego. You don't want to do the thing, but when it's marketed as something like this is about quality of care, this is about excellence of provision of care, you can't back down from that. And we all have the same values. Like all of us are in this because we actually wanted to help patients. But the other side of trying to incentivize people to do the right thing is to give them more positive support. I am not going to lie, I have used Google Translate before. The reasons why: I didn't have access to the person that could help me translate or interpret for me. There was not, it was some reason why, our system is really, really great. I love it. Sometimes it's not 100%. And I needed to find a way to communicate with this patient in a text form because that's what they were asking. And again, sometimes it's because that's how the patients are communicating. So making it easier for physicians to not do things like use Google Translate, make the thing that you want them to do easier than getting on Google Translate. Most of us, I am 40 years old and I love texting and I love technology. I still want to talk to a real person. Make it so it's easier for them to talk to a real person, and they'll get the context and the things that they need as opposed to going on Google Translate, because we know it's not right to go on Google Translate.
I'm going to hop back in here because there's a buildup, a logjam of questions that
Hold on, we got to hear from Dylan real quick. 1 second. Go ahead, Dylan.
Please. Well, I just think it's also such a great segue. So, I think a lot of what we're hearing about is, med school curriculum. HHS OCR knows that we have a med school curriculum. We are trying to reach as many folks as we can. If you're with a med school, please reach out to me. We'll try to bring the civil rights training to you. But importantly, Section 1557, we have proposed for the first time ever requiring that there be language access policies and procedures, that people actually get trained on them so that and your staff feels empowered to actually take that step, right? I know the number to call to get an interpreter. I know who can help me find maybe a rare language or one that's less commonly encountered in my area. Right. So what we have tried to do is provide the tools that those champions might need, right, to use to say, the government is requiring and providing these very specific guidelines. Now, obviously, that is a proposed rule that might change. Again, thank you for those who provided comments. But we really do think, to Dr. Tucker's point, this is about health equity, right? This is about preventing discrimination before it starts, be it intentional or not, right? And so what tools can we provide to help guide people to doing the right thing? And in this case, that right thing is the legally required thing, which is providing meaningful access to such critical care. So I just wanted to add that. And I do encourage folks to take a look at the NPRM. There have been a few different questions. One was about whether or not we are proposing standards for assessment. The answer to that is no, we are not. But, we definitely have tried to put in some scaffolding to provide more details and more supports compared to what we currently have. And I was in the hospital with my grandfather when somebody used Google Translate. So that was fun, but you work with what you have, right? And so how can we make sure that people have the tools that they need?
All right, Eliana, what do you got?
There's a lot of questions clustered that followed up after all those reassessing. How do you reassess? How do you guarantee that somebody that failed didn't go ahead and try to interpret anyway? And many, many examples in the chat of bad interpreting from someone that is not sufficiently fluent given. So what it seems to center around is that whether you're a staff interpreter or an agency interpreter sent on site or more and more frequently virtually, what is the pathway when you observe either non-compliance to Title VI or ADA or Section 5057, or you observe somebody very confidently displaying terrible second language skills. What do I do with that is basically where it all lands. What is the pathway? How do I report this? Where can I go? What do I do with this knowledge? Nobody knows how to file a civil rights complaint, and nobody wants to start something that big, but there needs to be a pathway for people to say, hey, I just observed this bad interaction done from a place of good intent, but this is not how we should be doing this. What do they do with that knowledge? Where can they take it? And something beyond your supervisor would be really helpful.
Absolutely. That's a great, let's start with that second question first. Dr. Tucker, any idea at your organization? What do interpreters do when they see a problem? How can they escalate that?
We have, I cannot tell you the title of the person, but I know exactly the name of the person that I call when we have problems with interpreters. And we also have, not interpreters, but with interpretation. If somebody, anyone, even if it's a clinician or not an interpreter, we also have an error reporting system, and our error reporting system is not anonymous, which I tried to establish an anonymous bias reporting system for the residents themselves, so that people who are afraid of, we can't ignore there's power structures, even if we say, most HR people in my experience will tell you, well, if you don't say who it is, we can't do anything about it. But with our systems and error reporting systems called SIRS, and you can file a SIRS, and there's actually someone who goes back and reads the comments, and they will get in touch with you. And you can put as much information in there as you can about who was involved and how it affected patient care. In my experience, what they usually try to do first is get the people who are involved to have a conversation about it themselves. And it also has to do with cultural change, because if people are not interested in filing SIRS, then none of this is going to work. So whatever champions you have in your area who are interested in doing this, I work with a lot of learners and trainees. So I feel like it's kind of my job to tell them, you must file a SIRS on everything, because we can't get better. I file SIRS on myself all the time. If I should have filed a SIRS that time I used Google Translate, I should have filed a SIRS on myself. But yeah, that's how we get things to change. We have a really great, as Vanessa pointed out, we have a really great, strong language access policies within our organization. So when people work outside those policies, there is recourse. People will have the conversation with them. And the culture in our organization is such that really just having the conversation with someone is probably enough to get them to change the way that they're doing things, because we have such strong, most people are very dedicated to our mission and our values, that even if it was Avlo, if it was Vanessa in the past, came up and said, like, I noticed that you're having this issue. This is not the way we do things. This is incorrect. It's causing damage to patient care. That I think most of the physicians, even if their initial reaction wasn't like, oh, I'm so sorry, like, how could I stop from doing that? It would definitely be a conversation that would say, well, I really don't want to do it that way. How do I do it the right way? Because I don't have the resources, or I wasn't aware of the resources, or I did it because it was easier and I need help. Help me.
Thanks. Carla?
I'm going to be real transparent in this. The interpreters would find people almost on a daily basis doing things like this that were totally unacceptable. And yet, because of the power dynamics, sometimes between a doctor and interpreter, a nurse and interpreter, et cetera, it almost looked like they were ratting them out, So we always said, from a leadership perspective, go see the nurse and just say, hey, just as a reminder, I'm here. You've got the iPad, you've got the phone at the bedside, take the assessment, encourage them, take the assessment. That way you'll be all set to be able to speak clinically. And the one way to really tell, what I ended up doing was I ended up putting a QBS SP for Spanish, QBS POR for Portuguese. It's a little sticker that goes on your ID badge, almost like the flu vaccine sticker, so that at a glance you could tell whether the person was credentialed to do so or not. And those stickers were handed out only to the people that passed the credentialing. So it was really easy to see whether somebody was credentialed and able to do so, because sometimes if I'm a manager and Dylan's speaking Russian, I can hear that she's speaking Russian, but I don't know if she's doing it clinically or she's talking about the Red Sox. So again, it was a gentle nudge just saying, hey, if you're using that clinically, please remember that you're not allowed to by policy. But your policy you have to live and die by. Sometimes it's easier not to have a policy on certain things because once it's written, you have to abide by it, and it has to be an extensive policy. So we had it all outlined in the extensive policy, but at the very beginning, the interpreters almost felt that it was us against them because it was becoming a little bit hostile in a sense that they felt like they were policing the staff when their managers were standing right there and they could hear it and they could see it and they weren't addressing it. So it took a little while for us to kind of get in sync. We call them incident reports, Dr. Tucker, at least. And there was some argument with me once about whether this should be an incident report, because it sounded like it was more like, interdisciplinary type of thing. And I said, no, it's a safety and quality issue. It's definitely an incident report. They are not following policy and they're not competent. At least we don't know if they are. They could be, but we don't have that assuredness with the credentialing that they are and that they can be able to perform that duty in another language. The biggest thing that was also a challenge was as soon as I put that little sticker on one of you, the doctor who was the neurologist would say, hey, Dylan, come on in, you can interpret for me. And obviously being assessed as a bilingual clinical staff language, QBS, does not allow you, it prohibits you from doing an interpreting role because it's a whole other skill set with a whole other list of qualifications. And you're putting yourself in harm's way. I've heard of 2 hospitals in the country where well-intended employees that were bilingual were interpreting because they didn't have any resources really to speak of. And when things went bad, the hospitals said, well, they went rogue. They were not operating under the scope of their job description. And guess who? I mean, the 2 hospitals got sued, but so did these 2 employees. So again, no good deed goes unpunished sometimes is not a good way to look at life, because I'm very much an optimist, but you really have to cover yourself, and getting assessed helps you cover yourself for liability because you're following the policy and you've been vetted by someone else. So it's not just your mother saying you're super smart. It's somebody that actually does this for a living. Try not to put your interpreters in that position where they have to be the ones to, quote, tell tales. But they would tell tales. They tell the manager of interpreter services. Then the manager would track it and then would go speak to the person. And not their manager, to the person as a courtesy, adult to adult, professional to professional. Do you know how much time and work and effort this takes? But it was those small little things that started moving the needle. And then, of course, if they still belligerently ignoring everything, then you go to the supervisor and you continue to fill in the incident reports. They do get looked at. They very seriously get looked at. But all of this is really interesting because when you're speaking to a person, a patient in another language, and Dr. Tucker, I think you have this set up, you still have to document that this was an LEP whose preferred language was not English. And how did you communicate with them? Because they're not going to know that Dr. Tucker was credentialed when they're reviewing the patient's folder or records for Joint Commission. And I believe you have a system in place, and you can speak to that. But at our facility, we had a system in place in the medical record that the provider, if he or she or the clinical staff was a QBS, they could actually check off the box that's saying that I myself communicated directly with this patient. So that when you didn't see the interpreter documentation, you weren't wondering, how did somebody communicate with this patient? It was clearly delineated that it was the provider who was assessed and credentialed that was providing language concordant care.
Absolutely. We have in our electronic medical record on the panel that has the patient's identification, there are 2 language references there, and one is the language that the patient I'm looking at right now because I have a patient that just walked in. I have to go see the language of care, and then also the language that they prefer to speak. And those can be two different things. They could be the same things. And when you see the patient, as somebody, I don't know, I did not know the terminology QBL, but because I have the credentials to speak Spanish with the person, I can put in there. There's a little box that we check that says this was a televisit, this was a video conference, this was in person. The patient preferred, the patient is it doesn't say competent. I'm forgetting the words that they use, but it says the patient preferred to speak in, was able to speak in English, or you were able to speak in the patient's language that is not in English. It also has on there, unfortunately, and I think it's for liability purposes, if the patient, you offered them interpreting services and they said, no, I prefer to have my friend or my family member speak for me. But all of those are options that you cannot sign the visit until you've checked those things off. And they made it even, I would say, even more of a big deal once we started doing televisits and video conferences, because they didn't want people's language concordancy to fall by the wayside just because we had the opportunity to do televisits and video visits.
Thanks.
Excellent.
Mike or Dylan, any other avenues for raising these concerns? I mean, if you're working outside of a hospital, you may not know how do you file a SIRS or an incident report or a safety report or whatever at that organization. What can an interpreter do?
So we do have our own complaint processes. So you can file a complaint with HHS OCR, with the Department of Justice. They don't have to be these sort of, you're not filing a legal brief, and they can be done anonymously. Unfortunately, Michael and I are both very familiar with retaliation, particularly experienced by interpreters. And so we don't want to imply that that doesn't happen. We know that it does. Also, we are proposing in the section 1557 regulation that every health program or activity have a section 1557 coordinator. And so, ideally that person is somebody that could be gone to. There's also a grievance process that we propose there as well. I do know that folks are mentioning in the chat that the Joint Commission, I believe, also might accept complaints. Mike, anything to add?
Yeah, I was just going to add that, onto Dylan's point about having a designated person, I think it's really important that person is not only designated, but that they have a level of authority that they can have that conversation Carla was talking about, that they are at a level in the institution to have enough authority to change what happened or to address what happened sufficiently. As to complaints, I know entities we work with, and actually Dylan and I have specifically worked with, we've asked them about their complaint process. How accessible is this to the person who's LEP? Yeah, it's only in English. That's not going to work. That's not a useful complaint system. Yeah, you have a complaint form. Could I ever understand it in my language? No, that's not a useful form. That's not something that's going to help anybody that wants to file a complaint. On interpreters do have codes of ethics. They have to adhere to confidentiality. I've heard from a lot of interpreters, they feel conflicted sometimes about holding to that ethical mandate of being confidential, but disclosing something that was really inappropriate or the wrong way as far as language services. So how do you balance that? I think Dylan's exactly right. Almost every complaint system I know of allows you to file it anonymously. We have had retaliation against interpreters, but we've also had situations, in specific situations, where we've also gotten monetary penalties or assistance that's paid to those interpreters, because retaliating against someone in and of itself is a violation of the federal civil rights laws. So if you retaliate against someone, that in and of itself is a violation of Title VI or 1557. So that's yet another violation if that happens. So understand that it actually is standing alone a type of violation of those civil rights laws. The other thing I don't want to miss is some states have very good or very broad state human or civil rights laws too, that allow for complaints to be filed with them, and also state departments of health, or whatever the state health agency is called, sometimes might have, and I remember my home state of New York had a specific interpreter regulation, and so you could file a complaint in violation of the regulation, which is not a federal thing, but you might have a state law or state ordinance that allows you to file a complaint on those bases as well.
And Andy, I mean, don't forget that you have patient advocates at every hospital, a patient advocate usually in the role. So if the patient says something to you as the interpreter, jump on it. Don't resolve it. My interpreters at one point, like if the patient was complaining that the nurse was rude or they didn't give them the water, after checking to see if they could have water, they'd bring water or a blanket. And I said, no, don't do that, because it was amazing. LEPs were never complaining, according to the hospital, because we were resolving and mitigating all the complaints. So they weren't hearing about him. So have the patient advocate come down, have them note that. Also, if you can, my best allies were risk management, quality, and compliance. So if you can get yourself in with those folks, have them sending them this webinar, have them have these conversations, then that is your best bet, because they truly are committed to making sure that the organization remains safe and that everybody that's employed there remains safe. I mean, one of my preferences is not to use dual role interpreters or staff that are dual role for various reasons. And my risk management helped me to secure that as best as I could, but I had to prove it. Couldn't just because Carla doesn't like it. I had to prove my reasons why, and we had to do audits of charts, etc. But get them on board, get the CMO, get the CNO on board, and then also remember the power struggle. There are so many bilingual environmental services folks, you know, that see so much. They see so much. They see what we do every minute and no one pays attention. Get them involved in the conversation, get their feedback about what's happening, and then take those nuggets and present them to your risk person without saying, you know, Susie in environmental services told me this.
Thanks. That's really helpful advice. I want to ask one really precise question. Carla, in one of the examples you were giving, you said that a manager can hear this clinician speaking Russian, but doesn't know if it's clinical or if it's non-work related or more of a friendly conversation. And I was curious from the compliance perspective, you know, Dylan, is there a distinction between clinical content and, hey, how was your weekend conversations with patients or families in a healthcare setting, and what regulation applies to that?
Sure. So we require that, you know, folks have meaningful access to the program. And so that changes, right? Like the conversation may be different if we're talking about discharge instructions or, you know, getting pre-surgical, you know, approvals and explanations compared to, you know, the front desk person handing over a diabetes information sheet, right? So, you know, we don't necessarily get into the granular. The conversations that the complaints we get are when a conversation should have happened with a qualified interpreter or bilingual staff member in the context of generally healthcare provision, and it did not happen. You know, that's really, we're not so much worried about the conversations, you know, that might be happening in the waiting room as somebody walks in and you're just, you know, being nice, right? This really, for us, is about the provision of care. And that is a huge range, right? Like, so maybe as I'm handing you the diabetes information form, I might not be speaking your language, but if you need to know what that brochure says, and it's not in your language, then I should get somebody who can help, you know, do a site translation or provide it in your language.
And Andy, for me, a colleague of mine from Massachusetts, a dear friend, actually turned me on to a program that I started that's called Yo Hablo, Eu Falo, Je Parle. And it was like a little button that said Yo Hablo. And it was really because people are so proud of their language and their heritage, and they truly want to help. And the cultural humility and pride needs to be cultivated. So if somebody from environmental services spoke both Portuguese and English, we would assess them to make sure that they spoke enough just to give logistical directions or to greet a patient or to say, oh no, the elevator's down, go around the corner, you know, and they would all be wearing their Yo Hablo. One of our hospital had probably, you know, 48% Spanish speaking patients. Every time I'd go visit, all of these staff people would high five me with a yo hablo, because they were just so excited to be able to contribute. So there are ways that we can, manage this, because all we're doing is building allies within the walls of the hospital that live in the community. And they're just so proud to be able to help. The key is to make sure that they know that it's logistical information only, that they are not able to interpret. And again, with the people that are the qualified bilingual staff, as I call them, that even though you're a resident, and this happened all the time, and your attending is telling you, well, you interpret for us. And you're supposed to say, no, I am qualified to do this myself, but I'm not able to do interpreting. And some of the residents oftentimes would also be black and blue, literally, because the answer was not acceptable to their fellow they're attending. And Dr. Tucker probably has more experience on that than me, but somebody has to stand for them.
Yeah,
Because
there's
they're doing
too
the right
many
thing,
times
you know?
when they, too
But
many
again,
times when they're
there's
doing
many
that.
ways
Yeah.
of us to use it. Yeah, it's sad because we're all in this together, and it's lost sometimes, that humanity that we need to bring together. But if you don't have a program like the Yo Hablo or Yo Falo, it's a really easy one to do. They sign an attestation, say that they know they're not able to interpret, which, by the way, Andy, helps me, because these people were being pulled in to interpret all the time. So now we have something formal that says, I understand, but yet they can have some pride in helping patients. And the other thing that's neat is a Cantonese speaker that worked in phlebotomy. She met this doctor that had a Cantonese I speak button on, and he did not appear to be Chinese. And the two of them looked at each other, and all of a sudden another relationship and discussion took place, and they connected on a very different level, because he spent years in China providing medicine.
That's fantastic. We're about out of time, and I know I have a giant list of questions we haven't gotten to, but there's one that sticks out, which was about written communication. So everything I've heard in our conversation today around qualified bilingual staff is around verbal communication. Now, if we wanted qualified bilingual staff at our organizations to communicate in writing, would we have to assess those written skills, Dylan? Is that a separate skill we need to be looking at?
Yes. I mean, I think if you are working with a bilingual staffer, right, that assessment should cover their oral skills as well as their written skills if you are expecting them to provide written communication. Our regulations speak, to translation, qualified translation. We propose special protections based on or special rules for machine translation. We do have, I know we're running out of time, Title VI and 1557 require the translation of written documents or vital documents. And so there's sort of a whole separate webinar that we can have.
Yes.
But I think, when it comes to what is your bilingual staffer allowed to do, that is, I defer to Carla, but that should be part of the assessment, right?
And again, I'm not going to assess somebody that never is going to write to a patient. But if you're communicating through a patient portal or texting a patient, absolutely. The partner vendor that I utilized actually had a discharge translation assessment, because in most cases, that's what you're translating is discharge information. So at least that was another vetted way to be able to do this. And then they also had a translation. But, the discharge translation, in my opinion, having seen what it does, was sufficient, because it's not like you're going to write a book. It's short, segued sentences that can literally be life or death if you don't know how to write it correctly. So look into that. And then obviously that should be part of your policy.
And I was just going to jump in and say, if staff that are not trained or assessed to provide translation, whether it's the electronic written by email or handwritten, which I know no one does anymore. But how would another staff person request a translation? I know it seems so easy, but how would they make that request? How would they ask for, we have this new form coming out. We have a large, let's say, Spanish-speaking Haitian Creole. How would we request that? How do we do that? Is it part of our rollout? We're going to have a new form for this. Is it part of standard operating procedure that we have a translated version for? If those questions are still questions and staff doesn't know how to do that, how is the community you serve? Remember, this is a service area. If word gets out, you don't provide information, you don't have information, you are not a place they want to go. They're not sure they're going to get the information they need.
And while we do have the forms and we know where to follow up to get the forms, and we complain about the forms that are not done right, we have a really great patient advisory council that tells us like, this is not what you're trying to say. It's still different when you as a provider have to send a message to someone explaining their test results. And most of us try to call people on the phone or see them in person. But as I mentioned before, it's really hard for clinicians these days to try to get all this done in this certain period of time. And I just cannot impress enough that we really do need more time in the visit. It is, I'm willing to admit that part of it is we're not patient, but 20 minutes to do everything that the patient wants them to do in a different language, it's just not, it's not feasible. We're not doing it. We're late to all our appointments.
More billable time, Dr. Tucker.
Billable, and that's the word,
let's
because
just
when we say,
billable time.
yes, because
Yeah.
we need the incentive. What is it that you said, the mission without the margins?
Exactly.
Yeah,
I learned it from
absolutely.
the nuns.
Well, I
Thank
hate
y'all
to
so much.
jump
I'm gonna
in,
run off to
guys,
do
but
patient
we
care. I'm
have
so
reached
thankful.
the end of our time. And there's
you.
so much good stuff going on in the chat. Folks who asked about membership, first year membership with National Council is more affordable than subsequent years. Those are the only two tiers, first year and sustaining member. And join the groups on Facebook or LinkedIn, connect with each other. I see a lot of people wanting information about translation or getting further training in translation. That's also been suggested as a future webinar topic. We take all of this to heart. Your comments really mean a lot to us. So engage with us so that we can share anything that comes out of today's discussion, like the pathway for reporting bad behavior in terms of language access. Anyone else want to add anything? Because we are now officially 1 minute over.
I just wanted to
thanking
thank you
everyone.
all panelists. Thank
Yeah.
you for your amazing
Thank you, everyone.
contributions, for your passion for language access. Thank you, Jennifer Moyer and Debbie Lesser, for interpreting this conversation.
Thank
I
you
look
all.
forward to seeing everybody at the next
Thank
NCIHC On The Road webinar coming up in a few months.
You bet.
Thanks for
Thanks so
having
much.
us.
Thank you all.
Bye
Thanks for
now.
having me. Bye.